Well, hello, afternoon, everyone. My name's Mamta Sohal. I'm one of the haematology consultants based here at Hammersmith Hospital. I also do a paediatric benign clinic at Hillingdon Hospital, where I used to be a consultant. I couldn't leave that clinic. Uh, and uh, and this is a talk today on transition of hemoglobinopathy patients from paediatric to adult services. And it's presented to you by the teams, both the adult side, at Hammersmith Hospital, the paediatric side at St Mary's Hospital, and also the Central London Community teams. And this is not to say that we would say that Imperial we provide an exemplar service. It's certainly something. There are certainly things that we do very well, but there's definitely things that we would like to do better. And hopefully this talk sort of will discuss some of the challenges that we face. Oh, next slide. So the topics for discussion today are the recent NCPOD report on transition, which I will present, and then our CNS colleagues, both in the adult and paediatric sector, will discuss the experience of transition at Imperial. And then Gaia, one of our SPRs on the Northwest London rotation, who's training to be a paediatric haematologist, will discuss a project she did around transition, and then we'll summarize with sort of next steps. Next slide. So the NCPOD report, which was titled The In-Betweeners, was a review of the barriers and facilitators in the process of the transition of children and young people with complex chronic health conditions into adult health services. Next slide. And they wanted to explore the barriers and facilitators in the process of the transition of children and young people with chronic health conditions. And they did this through organisational questionnaires, clinician questionnaires, case notes review, patient carer online surveys, focus groups, and health and social care professionals survey. Next slide. They were looking at young people aged between 13 years and their 25th birthday, transitioning from child to adult services. And the data was collected over an 18-month period from the 1st of October 2019 to the 31st of March 2021. 12 conditions were chosen to identify a broad sample of young people with complex chronic condition for inclusion, and they were identified using one of the included conditions by the ICD codes or the SNOMED codes. Next slide. So here's the conditions listed there. You can see sickle cell anemia was one of the conditions that they looked at. Thalassemia never seems to get much of a look in, but that wasn't included here, but sickle cell was. Next slide. So over 230 organisations participated. That's about 83.5% hospitals. There were survey data and focus groups. They also did surveys for young parents and carers. So they got surveys back from 50 young people, 79 parents and carers. They also did sort of 4 small focus groups talking to patient carers. And hopefully this will make Gaia feel better when she discusses the group that she did. They, considering this was a national study, they managed to only interview 3 young people. Next slide. And overall, as you can see here, the quality of the transition was rated based on all the assessment data. And as you can see, in about half of the patients, it was felt to be poor or unacceptable. Next slide. So, when they looked at the organisations, 68.2% of the organisations said they had adolescent services, and only about a quarter, or just under a quarter, had an adolescent ward. Only about a third had an adolescent clinic, and about just under half of the organisations had at least one clinical lead for transition. So these key messages, I mean, they're not, they seem very self-explanatory, but they say that it's developmentally, appropriate healthcare should be seen as a core business. Patients and parent carers should be involved in healthcare planning. There should be good communication and coordination between everyone involved in the transition process. Services should be organised to accommodate young people who are transitioning to adult services. And strong leadership is needed for all senior members of the healthcare organisation, including commissioning bodies, by providing sufficient funds for infrastructure. So before I go on to I sort of conclude with their recommendations, just handing over to the CNS team from Imperial to discuss how we run the transition services here. Is it Caroline who's going to do the presenting?
Yes.
Okay, over to you, Caroline.
Thank you.
Lewis, can you put your camera off, please? Thanks.
So my name is Caroline Cheo. I'm going to present on behalf of the Paediatric and Adult CNS for Imperial College. So transitioning clinics for young adults, we start with, we do early introduction to the hematology team, and this is done through joint clinics with the pediatric team at St. Mary's. We have approximately 10 joint clinics per year. And the adult team and the pediatric team, they have joint clinics whereby they introduce themselves. The hematologists and the clinical nurse specialists, they introduce each other to these young adults. The aim is to build their knowledge in the disease process and promote self-advocacy. Three main questions are asked during these clinics to these young adults, and these are: what are my choices when I move to the adult setting? How do I get support and help or make the right decisions for me? And what good or bad about the choices that I will make? So the CNS nurses would have a short meeting with them prior to seeing the consultant. They will write out their contact details, and they will introduce to them further ideas like tours to see the adult setting. And this is usually done by verbal communication or via emails. And during these tours, we also promote social and communications. Next slide, please. So this Ready, Steady, Go transition tours talk starts from the age of 12. So from 12 to 13, we start to introduce them. And by 14 to 15, we are somewhere in the middle, whereby we check their knowledge base on their disease. We check about their understanding of consultation and what they could gain from it. We also check about their general health, and also their growing up, whether they have any issues with puberty and so forth. And by the time they reach 16 to 17, they are ready to transition to the adult settings. Next slide, please. During our transitioning tours, that usually takes place during school breaks. Potential candidates are informed, as said, via emails or via messages. And this assembly point is the Hammersmith main building. So from the Hammersmith main building, we would have a tour to the RHT unit, which is the renal hematology and triage unit, where it's like an A&E for these patients when they have sickle cell crisis. we would have a little look around in there and a chat with one of the charge nurses in the unit. And then we'll move on to the inpatient unit, which is the Fraser Gamble unit, whereby we'll meet the ward manager or the link nurse at Fraser Gamble. And we'll have a look around again and another talk around there. And we also go and visit the apheresis unit, which is the red cell exchange unit. And we'll have a talk there about what red cell exchange is about. Some of them are already on red cell exchange programs and they are familiar with it. We visit the day unit where we have other outpatient treatments and also the outpatient consultation areas. We promote meetings with our consultants and they introduce themselves to these new young adults, and with the research team can meet them at some point if possible. And we also visit the phlebotomist areas. We visit the outpatient pharmacy and meet the clinical psychologists or the sociologists. Next slide, please. So pre-existing modifying factors, we talk about their knowledge, what they already understand by their disease, and we fill in the gaps. Skills and self-efficacy, beliefs and expectations, developmental and maturity issues, goals and motivations, relationships and communication. We strongly promote that they would be aware that they can contact us at any time and we will listen to them. And also we promote contact with the psychological and emotional team for emotional support. Next slide, please. So we always want to listen to these young adults. We like them to feel comfortable when they join our teams, and we are always happy to guide and support them. It can be we understand that it can be very daunting for them leaving the pediatric team and joining the adult team. So we encourage them to understand that they are not, although their parents will not be there for them, we are there to support them. We are happy to guide and support and teach them about some of the changes that are happening in the adult settings that were not in the pediatric settings. We make sure that their referrals for healthcare is done when they move places, say going to the universities and colleges away from their primary trust. We support with appropriate university accommodation allocations and also follow-up appointments for them to make sure that they have their yearly checkup with their primary trust. Thank you.
Elizabeth, are you happy to present your slide on community?
Yeah, I will. Yeah, so hello, everybody. As a community service, we work in collaboration with the acute service, and that is the Hammersmith Hospital and other acute services that host our patients. So in Hammersmith, we work together. We introduce the adult hemoglobinopathy nurse and the service. And then we have a brief discussion of the role of the adult nurse as part of the MDT and support system in the community towards independence and accessing other services, such as social services, housing, and other youth-related services. And then we do health promotion and education to meet their holistic needs, especially discussing relationships, because at that time they are really transitioning into a world whereby they're going to admire partners. So we talk about what kind of a partner suits them and other services that are available in case they need other support, like sexual health services. And then we also aim to build a good working relationship with them. So I do have Emma at the back because they're used to her in the community. So we aim to have our clinics jointly until when I have built a good relationship with them, and then I can single-handedly meet up with them, but we aim to have our clinics jointly. And then the liaison between other services and patients, like follow-ups, post-discharge, housing letters, college letters, and liaising with acute regarding prescriptions as well, if they need prescriptions or if they're trying to contact acute and they can't get them. So we are like a bridge in between. And so we emphasize on the collaborative working so that we sort of like avoid, I don't know what the right word is, but we emphasize that we work together and we do communicate. So whatever we discuss, unless it's very confidential, we will have to share it with our colleagues, GP and significant others if need be, or if there's a risk. And then we give community service contact numbers and location, that is at the Woodfield Medical Center, and also tell them we can visit them at home, and also signpost to other available services in the community like OTs, dietitians if they need them, or tissue viability nurses for those who have ulcers. And we liaise with those community services to ensure that the patients have attended and they've had a good experience. And then we reassure them of the pediatric nurses available to support transition through joint contact in the community. I've been caught off guard, so hopefully I hope that helps.
Thanks, Elizabeth. That was fantastic. And now just go on to the next slide. Just hand over to Gayathriy, who is one of our haematology SPRs, who put a lot of work into organising this adolescent transition focus group. And an extra thank you to her today for doing this, because she's doing this on her maternity leave. She was very keen to present her work. So thanks, Gaia, and over to you.
Thank you, Mamta. So, like she's mentioned, I do have a background in paediatrics. So transition has always been quite dear to my heart, and I really wanted to take up this project so I can see how transition works at Imperial. So I'll be presenting the outcomes of the focus group today. Next slide, please, Ralph. So transition is as a marketed active process to the medical, psychosocial, and educational vocational needs of an adolescent as they move from the child focus to the adult focus healthcare system. And this spans from early adolescence to adulthood until a person adjusts to and is fully established as an adult patient in adult care. Next slide, please. And as we've mentioned already, it's important to obtain patient feedback in order to improve the service and tailor it to the needs of the user. So I set out to do this by conducting 2 surveys for both the pre-transition young people aged 16 to 18 at St Mary's and young people aged 18 to 25 who've transitioned over to the adult care at Hammersmith with a background of sickle cell or thalassemia. So we did this as a SurveyMonkey link, which was emailed to the eligible patients. And for those attending clinics or for their exchanges, a QR code was generated and presented in person to help improve engagement. However, like most teens, despite spending most of their time on electronic devices, completing an electronic survey was not too appealing, and we had quite a poor response rate. So then I decided to kind of move on to the next phase, which was a face-to-face focus group. So in order to make it more engaging, we tried to promote the evening as a social evening. We provided pizzas, soft drinks, and made it an opportunity to meet other young people with sickle cell and thalassemia. So we went about inviting young people aged 21 to 25, as we wanted young people who had already had some experience in the adult services at Hammersmith. Young people were invited personally by telephone, and we received really positive and promising engagement over the phone. And we even made it a hybrid event, sending out a Teams link because some young people weren't able to attend in person. Next slide, please. However, despite such promising engagement, we only had 2 attendees on the day. So one was a 21-year-old female with a background in sickle cell disease who had transitioned from St Mary's to Hammersmith. The other attendee who attended virtually is a 23-year-old male with the background of sickle cell disease. He actually had very little experience with St Mary's Paediatrics because he had moved from Europe in his late teens and was predominantly at the Royal Berkshire and Portsmouth during his university years. However, he did have some experience of coming to Hammersmith for his annual appointments, and he has previously been transferred to Hammersmith for tertiary level care twice in the past. Next slide, please. So throughout the course of the evening, we presented the attendees with several questions to initiate a discussion. So the first question was, what does adolescent transition in healthcare mean to you? So the main points that we discussed from this was that it is an important phase in their life in which they move gradually from pediatric care to adult care. And it involves them taking control of their own health from their parents. It's an opportunity for them to get to know healthcare professionals for themselves, and they felt that they should be supported along the way of the transition. Next slide, please. So we next approached the question of how they felt when they moved to adult services. So this word cloud demonstrates their personal feelings, such as feeling overwhelmed, worried, scared, but also the thoughts of the service, such as fear of the unknown, less personalized, less supported, less friendly, and the adult service was very busy. Next slide, please. And leading on from this, we discussed what barriers they felt there were to transition. And just like other young people with chronic conditions, they felt that there was a big change between the paediatric and adult services. They predominantly felt that there was limited one-to-one care, and so they felt less supported. And they understood there was a big need to advocate for themselves, which they've not needed to do in the past in paediatrics, as they always had the support of their parents. And they also noted that was infrequent follow-ups with regards to clinics, or even being chased up, which made them feel quite lost. Next slide, please. So during the focus group, we also wanted to gain an understanding of their hospital experience. So with regards to outpatient clinics, these clinics were still being conducted virtually. So due to the pandemic, young people were already feeling quite isolated. But as the clinics continue virtually, they feel they had very little contact with the adult services, especially those who had only annual appointments. Compared to their paediatric experience, they felt quite anonymized, like any other patient, and rather than having the personalized approach which they had previously. And from witnessing the clinic, they also found it quite big and busy, with a lot of older patients present too. They were hoping to meet other young people with the same condition as them, but that wasn't their experience. And with regards to our day unit experience, only one of our attendees was a Hammersmith patient, but she was very complimentary of the exchanges that she has. She was very grateful for the exchanges being on the weekend to help accommodate for her college days, but she found that this was actually much quieter and more private. She also appreciated having female apheresis nurse to access her portacath, understandably. She also was exchanged by the same nurse, so it allowed her to build a good rapport and trust with them. She did mention that she hadn't needed to attend the day unit for pain relief, but she wasn't entirely sure how she would go about that. Next slide, please. So when discussing inpatient experience, our Hammersmith patient hadn't actually been admitted since her transition. However, she did mention that she wasn't entirely sure how she would use RHTU if she needed it. She didn't remember even seeing it on the tour or having a tour, and felt quite nervous if she needed to use it. With regards to our external attendee, he had really interesting feedback about his inpatient experience. He found, compared to paediatrics, that the emergency department and acute medical units were a lot more busy, and the medical staff had very little knowledge about sickle cell disease. He particularly noted that hospitals outside of London had very little experience in managing patients with sickle cell disease. and previously, out of sheer frustration, has actually self-discharged himself and attended his local hospital, who were a lot more familiar with his background. He was a lot more ease when he was on the haematology ward, as the staff were a lot more knowledgeable and he felt that he could trust them. And he explained that he had to be transferred to Hammersmith for a tertiary level care from his local hospital in the past. And he found that whole experience quite daunting, especially as he was acutely unwell in a hospital that he wasn't familiar with. Next slide, please. So following on from this, I brought up the No One's Listening inquiry. And interestingly, neither of the attendees were familiar with this, but they were both well aware of the case of Evan Nathan Smith, which was a key precipitator for the inquiry. Next slide. So this led on to our discussion about their personal experience with healthcare professionals. And an interesting point, as a registrar working on the wards, that we don't really think about is the interaction that patients have with the ambulance staff. One of our attendees described a particularly difficult encounter with paramedics who were unaware of the acute management of sickle cell disease and even asked him what needed to be done. They weren't particularly rude or mean to him, but just not knowing what to do in that situation made him feel uncomfortable. He felt that he couldn't advocate for himself when he was in excruciating pain, and just left him feeling frustrated and lost faith in healthcare professionals in general. Further to this, in the acute medical unit, as we all know, felt quite busy and stressful. Therefore, he struggled to get appropriate pain relief in a timely manner. And more worryingly, he overheard nursing staff using statements such as, "He's an addict, not in that much pain, not yet due pain medication, you'll have to wait," and overreacting. The lack of sympathy and understanding made him feel more distant from the medical team. Furthermore, even some doctors appeared to be unfamiliar with the management of sickle cell disease, leading him to question, "Am I safe here? Will I make it?" And these aren't questions that we should be asking when we're admitted to a ward. The key point to take from this is that young people are learning to advocate for themselves, and sometimes for the first time during their first few admissions to the adult ward. During their time in paediatrics, they always had their parents or specialist nurses taking lead in their care, but now they're taking more of a shift of the responsibilities to themselves. So it's really important that a bad experience can have a lasting impact on their further interaction with healthcare professionals. Next slide, please. So we next moved on to discussing general knowledge and understanding about sickle cell disease, which we divided into 3 distinct groups: their own understanding, healthcare professionals, and the wider community. So with regards to their own knowledge and their condition, one of our attendees stated that he only really learned about sickle cell disease when he was 16, as his parents sheltered him from it growing up, which is not uncommon. However, since then, he's done more of his own research online and feels a lot more confident and willing to teach others about sickle cell disease. Our other attendee, however, was well aware of sickle cell from a young age, and by sharing this with a close circle of friends, she felt more comforted that they will be able to support her when she's in need and not needed to explain why she was missing school or PE. With regards to healthcare professionals, they both felt that healthcare professionals needed to be more confident in the acute management of sickle cell disease complications, and particularly noted a lack of understanding in hospitals outside of London, who probably aren't experienced or not see many patients with sickle cell disease. When discussing the wider community, they both felt that more people know, the better. We also even discussed that there could be more media exposure about sickle cell disease to help with this. Next slide, please. And finally, we discussed about their overall experience of the transition process. Generally, they knew they will be moving on to the adult services, and transition was discussed before turning 16. They felt that there was initial support from the paediatric team, and parents were still welcome to attend clinics in the adult services to allow them to transition slowly. However, they felt quite isolated once they did transition, with a loss of support, which they particularly described from the community setting. They also noted that there was not as frequent outpatient appointments compared to the paediatric side. Most importantly, they felt, despite that the transition happening, they wanted to have had more clarity about the transition process and what to expect on the other side. Next, please. So where do we go from here? Initially, we need to look at the results of our post-transition survey to help support the findings of this focus group. We'll also need more of a drive to kind of get the pre-transition surveys completed as well. The findings of these should be presented accordingly in order to obtain more feedback and possible funding to help support us in further activities as well. I would say that the key points and suggestions taken from the focus group is that they would really benefit from a transition day for prospective young people, pitched as a social event, but also being able to provide key information about the tours and introduction to the team. Another thing that we can consider is having the adolescent clinic at Hammersmith rather than at St Mary's to make them more familiar with the adult setting. We could also join links with the ITP clinic, where they have an adolescent clinic based at Hammersmith, instead of the young people attending the generic hemoglobinopathy clinic, possibly up to the age of 25. It's also very clear that more education is needed for healthcare professionals, particularly in the acute management of patients, but also for the young people themselves, for education about their condition to start from an early age. And we also highlighted the importance of a dedicated CNS for transition in order to provide and support the bridge the gap during transition. One final point I'd like to mention is that it's clear that engagement is a real issue for young people. And I'm very grateful for our two attendees who are very articulate in describing their experience and keen to help improve the service. And having their continued involvement in developing the service enables young people's perspective, which we as healthcare professionals can't provide. And this may help improve engagement. Next, please. So finally, I'd like to say huge thanks to our attendees for their feedback. Also to Camilla, our paediatric SHO, who helped me conduct the focus group. Also like to thank HCC, particularly Ralph, for helping organising the funds for the day, and Dr. Lund, Dr. Oakley, Catherine and Emma for their support. Thank you very much.
Thanks, Gaia. That was very sobering. To say that I think when you did that focus group, that was their experience sort of during COVID, and actually during COVID at Imperial, we were in a transition period, and we actually didn't have any CNSs at that point, and now we're very lucky to have two very good CNSs on our team, and that has enabled us to start the transition tours and for them to come with us to the transition clinics and support the service. I don't know if people notice, but we hold the clinics in the early evening, so 4 to 7 p.m. So the young people aren't needing to miss school, because it's obviously a very crucial time for them around those in that age group for school. So to sort of maximise attendance. So back to the NC Pod report. So the recommendations that they have come up with from the report is that each young person should have a personalised transition plan, and young people, and where appropriate their parent and carer, should be copied into all correspondence regarding their healthcare needs so that they start to become familiar with terms. I found that quite interesting, that one of the people in the group that Guy was talking about hadn't really learned about sickle till they were 16 because their parents had cosseted them. You know, holding transition clinics, which we do. Request input into MDT for young people with ongoing healthcare needs, including everyone that's involved in their care, including social care and the education sector, not forgetting primary care, and then having an overarching health board transition team to provide a one-stop shop model of holistic care and to develop a policy. And then for all of us that are busy in our jobs thinking, where are we going to fit this all in? Having transition actually included in a job plan for all members delivering clinical care to children and young people with ongoing healthcare needs. If you have designated time, then you know things can actually be. You can actually develop a service if you've got the designated time allocated, and obviously ensuring appropriate training. And then, you know, making sure all young people who need to be moved are identified on electronic patient systems across all healthcare sectors. And then ensure it's specified in service outcome measures so that there's appropriate quality and outcome measures should be included in both adult and child service specifications. Next slide. This is if you want the full report of summary of the in-betweeners, you can find it on the NCPod website, and there's a link there. And there's also a link to the Ready, Steady, Go website. Next slide. Thanks for listening, and really interested to hear how others within the HCC have, you know, managed transition, and how we can get young people to engage in advocating for themselves and developing the services that they'll be using. Thanks. Hi, Indu.
Hi. I think within our services, what we tend to do is once the child turns 13 years of age, we actually call them on their own into the clinic room to get them talking to us about their health problems and discussing the meds, etc. And it does come across as pretty scary for them as well as their parents. So we try and reassure them in front of their parents to say this is just to get you used to talking about your problems. And then we're not trying to hide anything from the parents. And we say we're going to invite the parents in after we've had the one-to-one conversation, and then parents can chip in and fill in any blanks. That does seem to help. Having said that, when our CNSs have tried to conduct workshops for teenagers, they've had like 4 people come in, and the boys just saying mum and the girls interacting. So the usual boy-girl stuff. I was going to ask, what's the youngest age where you see them in the joint clinic? Because we only see them at around 16, not before that.
So the only way that Shams
I have in my head around sort of 12, 13 that they start, but Kajal might be able to.
It was noted. She took a little.
Stephen's got his hand up as well.
We have patients, I think, about from 14 that we
14, 14.
Yeah, adolescent
14, yeah. The adolescent clinics 14 to 18, and then they transition when they're 18 to us. You're muted, Indu.
Sorry, I was going to ask whether you see them every year from 14 onwards in the joint clinic.
So the transition clinic basically is like their hemoglobin. Yeah, so they're seen regularly in that clinic. So then they build up a relationship. The idea is, so there's 3 of us who share that clinic as the adult physician, myself, Asad, and Stephen. It's held once a month. As I said, it's held 4 to 7 p.m. And the idea, and Kirsten tries to make a point that they sort of come on the times when, you know, we have a rota, so they, you know, that so the same person, adult consultant, sees them with her each time, and then when she refers them to us at Imperial, then we become then, so they have name consultants, so we become their name consultants, so we become, you know, so they get to know us.
I'm not saying that, I'm just saying.
Thanks.
Let's not count.
Stephen?
So just a couple of quick things. Really good presentation, thank you. Particularly all the fantastic what the guy did. Her efforts, I'm sure, was quite demoralizing with 2 patients turning up. But I think there were a few things, a couple of points that she made that were really quite important. The first is the need to try and sort of translocate the service over to the Hammersmith for the patients, so they can be seen in a new environment with familiar faces, and hopefully that'll sort of smoothen some of the edges out. I know there are some logistical problems on our side in doing that, but I think that's something that's quite important we need to explore. And then the other thing is to try and introduce, I know we said that, and 14 is the time that we start to introduce transition to our patients, but we tried to set up a transition working group a few months ago, and we sort of struggled to sort of get full engagement with that. But I think there were several elements of some of the things that were said that I think are really important. We need to try and sort of engage with our patients a lot earlier. And I think this is one of the things that was mentioned by several members of the team, that sort of engaging them at 14, probably a bit too late. Doesn't necessarily need to be anything too dramatic, and it certainly doesn't need to be anything about transition, but engaging with the service earlier, I think, is really, really important, and trying to do that from a really early age, so single digits. And also the final thing I want to say is that to acknowledge this is extremely difficult. For those patients that don't engage, it's nigh impossible to do that. So we should acknowledge that and just to try our best to work sort of collegiately to try and figure out how to do this better. It's not great at the moment.
Yeah, Asad's right. Rightly reminded me in the chat that they normally alternate appointments between usual peds and transition, but we do see them continuously, so that repeatedly to build up a relationship. Asad?
Thanks, Mamta. Yeah, I echo the comments by Stephen about the great presentations and the great work. Just another point to add is it's a small point, but I think it makes a big difference. And these kind of small things, do tend to kind of help the transition process. Is that we tend to try and get the adolescents familiar with a consultant, and then when they come across to the adult team, we try and make it so that the same consultant sees them in the clinic where possible. So they've already kind of formed a little bit of a relationship with that consultant, and it's not all completely foreign to them when they come over to the adult. I think that helps. Yeah.
Mark? Oh, sorry.
Thanks. I had a question for Gaia, really, based on the feedback she received, and I'm looking at this really from the HCC perspective in my role there. The key part of the HCC's work is to try and improve health outcomes for both adults and children with hemoglobinopathies. What more do you think the HCC can do to try and support this really critical stage in the experience of young people with chronic conditions? And in particular, you may be aware from RAF that we have an active patient and public voice group within the HCC, and I wonder if there might be a case for trying to set up something that's tailored specifically towards young people within that.
Yeah, I think the big thing with young people is engagement, and they're more likely to engage if they see others similar to them also getting involved. And if we can form some form of kind of like adolescent PPV,
that's what I was thinking, really, because the numbers in any individual centre are quite small at any one time, but across the HCC, where we have patient population of around 2,500, there would be more sort of critical mass potentially.
And the two attendees that did come to our focus group, I did mention it to them, and they were both quite keen to get involved and participate in anything further in trying to improve the service. So I'm sure we'll be able to find others similar.
Okay, that sounds like an action point for Ralph. So we'll certainly take that forwards. Yeah.
Oh, there's a few hands up, I think. Elizabeth was next.
Hello, hi. I work at Lieutenant Dunstable Hospital.
Hi, Elizabeth. Hi.
Hello. What I have observed in my trust is, yes, you have all the support and facilities there in the pediatric setting for our patients, but there's no just another person similar to you in the adult setting. That is where we are struggling. There's unable to, there's no point of contact. That is where my patients are struggling. Yeah, I just want to add with all of you, that this is what the thing that I am struggling here. That is what my patients are having problem with.
Sorry, Elizabeth, you mean that there's not your equivalent in the adult
Yeah,
setting, like
absolutely.
a CNS?
Absolutely.
So, you mean if they go to the adult services in Luton?
Yeah.
So I think that is an issue, isn't it, in the district generals?
Exactly.
That that it's fine if you're moving to a teaching hospital, they will have hemoglobinopathy CNSs, whereas in a district general, I was a district general consultant for 9 years, so I know that the CNSs are there, but they're not
available.
They're not specialist hemoglobinopathy CNSs. They're CNSs for the whole of hematology, and their focus tends to be more on the malignant hematology, actually.
That's right.
Yeah, that's right.
What my trust is struggling here.
But they should have shared care with a tertiary centre, so they should. But I know that's not ideal.
Have, but yeah, exactly. They do have all sort of facilities available. But that easy access, when they need something, there's no one to contact.
No, that's
then
true.
gradually that relationship will fall out. That's the problem. They won't attend appointments, they won't take medicines, all those things happen gradually. Whereas when they are with pediatrics, you have a nurse, she's concentrating on everything, responding to their messages, providing the medications, all those kind of things happening smoothly. But when they move to adults, it's not happening.
I know some trusts have they have a transition CNS. I mean, that's certainly something we're looking at having at Imperial. But I know Hillingdon,
Luton doesn't have it. There, we really would like one, but so far we don't have one.
I think that would be, like as Gaia mentioned in her presentation, bridge the gap. That would be ideal. Elizabeth.
Thank you.
Thanks. Elizabeth.
Oh, hi.
Sorry, I put you on the spot, by the way. But,
it's fine. Okay, so this is just a question to Mark and Ralph. I mean, with the future developments and the changes that are coming, I've heard Gaia talk about transferring the clinics to Hammersmith. If that happens, is there a way that we can have clinics for just 18, for the transitioning group up to the age of 25, just to have their own space in the clinic, just a day for them, and then the other clinics can work that way? Is there a way we can change that?
Yeah, Elizabeth, thanks. I think Stephen mentioned this also, and from the feedback that Gaia received, it would seem there'd be a very strong argument for trying to cohort young patients in a clinic that would improve their overall experience. And it may be easier for all the relevant members of the multidisciplinary team to provide a more focused clinic for a smaller group. So yeah, I think that's definitely something we'll take away and explore here.
Helen?
Yeah, I was just going to say, in Cardiff, unfortunately, we don't have a youth worker at the moment, but there was a period when we had a youth worker in post, and they played a really crucial role in engaging our youngsters to, and she was integral in getting them to engage and come to our workshops and stuff. So getting the youth worker involved is really beneficial.
Elizabeth, do we have, we would have youth workers in within Hammersmith and Fulham, wouldn't we?
Not that I know of, but
We don't have them. Okay.
I know the patient group in Ealing that I normally go to. They have a small group of youth, so maybe I could follow that up.
Yeah, no, that would be.
And also, we intended to have patient representatives in the community, just volunteers, because we do have them for other services, and we were aiming to look at the youth and see from Emma's parent group, like people who can be patient representatives. So basically,
you know, you were talking about the someone bridging the gap between peds and adults.
Yeah,
that was the youth worker's role.
That
really.
was the youth worker.
Yeah, between the ages of 14 to 25. You know, they were the person that would see them through from peds to adults, and then they saw them in a non-medical way, and were able to engage them to attend things more than we could, in a way. Yeah,
that's really helpful.
Mamta, would the community psychologist that has been proposed by the community service, will that person be able to do that?
That's a question for Mark. Is his HCC hat on? But I would imagine it could, maybe, possibly.
The job description for that post is not finalised yet. So if there are particular areas that are seen as a priority, that there would be the opportunity to incorporate that. One area that we have already identified is neuropsychometric testing, and there's been some discussion about the new post having a dedicated transition interest. So any thoughts about that, Elizabeth, would be very welcome, appreciated.
Yeah, or maybe we could have a chat with you outside this meeting about what we were brainstorming about, and maybe you could support us with that and see, because it was about transition.
Yeah.
Will that be okay?
Yeah, we should have a separate meeting, shouldn't we?
Okay,
Gaia's got her hand. Gaia?
Yeah, I just had a question about, so I know the ITP team with Dr. Nicola Cooper, she's doing a transition, she's working on a transition model as well, and whether it's worth joining a little bit with the ITP. I know it's different, but they use kind of similar services, and it might be worth considering, because she was thinking of things like psychologists, and whether you have more of a I don't know, to be able to put the two together in order to go push for a psychologist, helping the adolescents.
Yeah, that's what we're working on, Guy. I think that's the plan, isn't it, Mark? Potentially, better together.
Yes.
I know that.
Although the funding that we have from NHS England is
purely for sickle focused,
and it's also pilot funding as well. So although in the longer time, if it was part of an established service, there would be some flexibility in terms of roles. I think we have to demonstrate that this is of benefit to a particular patient population in terms of outcomes, to ensure that the service is sustained.
Right.
I just wanted to ask, has anyone got a designated teenage young adult ward where they are? I know there's only UCLH within London, I think, has a designated ward, but that tends to be for hem-onc patients, but they tend to use the bed they say, oh, that the hemoglobinopathy patients can use the facilities, but Indu's got a hand up, so.
Yeah, I just wanted to say our TCT are very good at accommodating our patients, but our total numbers are much, much smaller compared to yours, so it's doable.
I think coming up to 4:30. Just wanted to thank everybody, thank the speakers for their time, and thank you all the attendees for a very lively discussion. Probably more questions than answers, but lots of work to do on sort of improving the transition pathways. And if there's no more questions, thanks very much for coming, and have a good week.